the antagonist of adrenergic system. Now let me tell. I hope you have gone through. We have discussed earlier. Please go through. Please go through pharmacology of all the agents which we have discussed. I have also asked you to read few things, and so far no difficulties has communicated. That means you have understood the things well. I'm happy to note it. Still, if you have any difficulty, you can ask me. So let us go for the this one, that is various antagonist for adrenergic receptors. So we know there are variety of receptors available. We know there are two basic receptor, alpha and beta. Then in alpha we have got alpha 1, alpha 2, beta 1, beta 2 and beta 3. So these are five different varieties of receptor. So we can have agents same as agonist. Agonist can be having action on all adrenergic receptors, that is alpha and beta, only on alpha or only on beta, okay, or only on alpha 1 or alpha 2, beta 1 or beta 2. So this type of thing we have seen during when we studied agonist. Similarly, same thing we can see over here. Various agents, various antagonists which are there, and where they are acting, how they are acting. So let us go for their classification. As I told you, alpha and beta receptor agonist. Then we can have non-selective. Non-selective means acting on both alpha as well as beta. That is phenoxybenzamine and phentolamine. They are acting on alpha 1 and alpha 2 both. So we call them as a non-selective. The agents which are selective on alpha 1, they are prazosin, terazosin, doxazosin. See, some of the names are very common, so it is easy to understand. So all zosins, prazosin, terazosin, doxazosin, alfuzosin, bunazosin, these all are the agents. And then there are new like tamsulosin, then endoramine, urapidil. These are various agents. They are acting on alpha receptor, particularly alpha 1 receptor. In this also we shall see these agents when we shall see various diseases. Most of these, what you can expect from alpha 1 antagonist, what action is expected, what do you feel what they will cause? What alpha 1 selective antagonist can do? Very good, vasodilation. See, Dheeraj and everybody, you are that way correct, but they will not cause vasodilation directly, okay, because they are antagonist. So just when you are writing or whenever you are answering in viva or somewhere, what we can say that they will prevent the action of alpha 1 which causes vasoconstriction, and thereby they will prevent vasoconstriction, okay, which cause the dilatation of blood vessels. That is indirectly. That means it can reduce blood pressure. So all these agents are used in blood pressure. They are used in the treatment of blood pressure. The next thing is the other one, they are more selective in the urinary bladder and particularly prostate gland. So tamsulosin and all, they are used in prostate gland inflammation. So this is another use. This is alpha 1 selective, which is useful in prostate disorders. Alpha 2 selective, it doesn't have much use. It was thought to be aphrodisiac. Aphrodisiac means which increases the sexual desire and activity. So it was believed that, but it is not proven and it is not known. Then beta antagonist, beta receptor antagonist. Again, we have non-selective. That means they are also called as a first generation because initially they were available and they were non-selective, and there are many of that. The first in that was the propranolol. Okay, here it is given uh, that is all these are there like nadolol, penbutolol, pindolol, and propranolol was the first one. So that is called as a prototype. Okay. Then timolol, sotalol, leobinolol, then metipranolol. These all are non-selective. Okay. So that means they can act on beta 1 as well as beta 2 and other also. Okay. Then next are selective on beta 1 only. Example of these are acebital, atenolol, bisoprolol, ismolol, metoprolol. These are all various kind of beta 1 selective. Okay. Then the third generation, but they are also non-selective. But the thing is, they are able to block alpha and beta both. Okay, carvedilol, example, then cartiolol, labetalol, bisindolol. So they are acting on both alpha as well as beta. Okay. And therefore, many times they are used because, particularly when very severe hypertension is there, so they can block alpha 1 also and beta 1 also, comparatively less beta 2. But yes, they have non selective. Then third generation beta 1 selective are betaxolol, celiprolol, and nebivolol. So, see, one thing you should understand or you should keep in mind is, usually there are few reasons why in certain category you find more drugs. One thing is they are highly used, they require repeated use, and they will be used in many patients. So, therefore, the research is going toward that direction. So you can find this in certain cases where you will find that there are many agents have been found in particular class. That means it has got good utility. We can understand what is the utility of this agent, that these all agents are used in various cardiovascular diseases. Again, as I told you, when we shall discuss cardiovascular diseases, at that time we shall discuss this. We shall again do the classification, but at that time you will be aware about basic activity. Only additional things we shall be studying about. So these are various adrenergic receptor antagonists. Let us see one by one some of the characteristics of these agents. Uh, First one we have seen, that is alpha. This alpha one non-selective. Example of these are phenoxybenzamine and phentolamine. So these are both non-selective. Okay. It has got phenoxybenzamine is having additional activity, uh, that is, it is also causing uptake 1 inhibition. You know now what is uptake 1. Uptake 1 means the presynaptic neuron is taking back the neurotransmitter, which contributes to again store of the neurotransmitter. So thus phenoxybenzamine is also having additional activity as a uptake inhibitor. It is alpha 1, it is non selective, it is irreversible. Non-selective means acting on alpha 1, alpha 2 both. Okay. When it is used in pheochromocytoma. What is pheochromocytoma? Pheochromocytoma is the disease of adrenal gland. Okay. That is a tumor of adrenal gland. Because of tumor, it is secreting more adrenaline and noradrenaline. We have seen that adrenal medulla is secreting adrenaline, noradrenaline. So this will secreting adrenaline, noradrenaline, and therefore in that case phenoxybenzamine will use, because it is irreversible, it is non-selective. So whatsoever additional amount of this adrenaline, noradrenaline is secreted, it will take care of it. What are the adverse effects? It causes postural hypotension, it causes tachycardia, it is a reflex one, and nasal congestion, because it causes this vasodilation because of alpha 1 blockade. It can cause impotence. It is orally absorbed. Plasma TFO is 12 hours, and the action is longer, very long, because even it is removed from the plasma. You know, remove from the plasma means we have called it as a clearance in pharmacokinetics. So even if the drug is clear from the plasma, the action will be seen. That means it is irreversible. That means what? It means it is bonding covalently to the receptor, and even the drug is not available in plasma, it is available on the receptor. Then next is phentolamine. Example of that is alpha 1, and this is alpha 1 antagonist. It is also non selective alpha 1. It is vasodilator, but Thing is, it is not acting on an uptake one in, or it is not acting on a uptake one, and it is a reversible kind. It is not irreversible. Again, it is rarely used. The adverse effects are same as penoxybenzamine. It can be given by intravenous and metabolized by liver. Plasma T half is just 2 hours. The agents which are very prominently used now, when we say here prazosin, that means all other zosins are there. Just now what we have seen, prazosin, terazosin, and all other zosins, they are having similar. Only thing is, they have a slightly different pharmacokinetic actions. Okay. So alpha 1 antagonist, it is reversible. It is used in hypertension. uh, the all alpha 1 antagonist will have almost similar adverse effects. That is same: postural hypotension, tachycardia, nasal decongestion, impotence, etc. It is absorbed orally, metabolized by liver. Plasma T of 4 hour. As I told you, doxazosin, terazosin, and all other zosins are similar, but the duration of action, that means pharmacokinetic and duration of action, will change. Okay, that again we shall see when we shall discuss it in as cardiovascular, because it is alpha 1 blocker are present as a cardiovascular. But I'll suggest you to go through it, read it before that. Okay. Then next is tamsulosin. I told you just now, it is alpha 1A antagonist, and therefore we call it as a uroselective. It is used in a prostatic hyperplasia, that is, prostate gland size increases. Okay. Uh, it will not allow ejaculation, is the adverse effect. It is absorbed orally. Plasma TF is 5 hours. Selective for alpha 1 alpha 1A type of adrenoreceptor, which is a recent finding. Alpha 2, I told you, eohimbine, it is alpha 2 antagonist. It is not used clinically. It can cause excitement, it can cause hypertension, because if you understand the mechanism, alpha 2 is a autoreceptor. When adrenaline binds to alpha 2 receptor, it will decrease its own release. Therefore, we call it as a autoreceptor. When we block this alpha 2 with yohimbine, that inhibition will be stopped. There will be no inhibition. This term sometime you will encounter, we call it as a inhibition of inhibition. That is, alpha 2 was causing inhibition of release, and if we inhibit or we block alpha 2, that will cause inhibition of inhibition. That means indirectly, just like minus into minus is plus, similarly it will be happening, and therefore yohimbine will cause excitement, it will cause hypertension. Okay. Then various agents acting on beta receptors. As I told you, propranolol was its prototype. Just now I told while classification, it is a beta antagonist. It is a non-selective one. It is used in many cardiovascular diseases. Basically, later its use has reduced because it is non-selective. It can cause some adverse effects, but some of the selective agents are being used. So we shall see the uses of beta blocker. We'll consider instead of propranolol, we'll put it as a uses of beta blocker. So they are angina, they are used in angina, they are used in hypertension, they are used in cardiac arrhythmias or dysrhythmias, they are used in some of the anxiety tremor, they are also useful in glaucoma. But I repeat, these are the overall uses of beta blocker. But we do have many agents which are, example, when we say about ophthalmic use, glaucoma, we are not using propranolol, we use timolol. Timolol is, yes, it is there. We shall go for that. So, bronchoconstriction, cardiac failure, cold extremities, fatigue, depression, hypoglycemia are the adverse effects. It is absorbed orally. There is an extensive first pass metabolism. Now, since I repeat, you have gone through all these things. You have seen absorption, you have seen distribution, you have seen metabolism and excretion. You know what is plasma TF, you know about everything, because pharmacokinetics is very important. Now everywhere this word will come, it is absorbed orally. That means the sufficient quantities are absorbed orally, which are effective in nature. If it is said it is not absorbed orally, that means maybe very small fraction is absorbed and that is not clinically significant, so we say it is not absorbed orally. Then extensive first pass metabolism. You know again this word, extensive first pass metabolism. That means when the drug is absorbed orally, it is administered orally. When it is absorbed, it goes to liver, and majority of the drug, very big fraction, will be metabolized. That means accordingly your dose has increased. Okay. Then next is again, we have seen factor affecting distribution or important factor. About 90% of the drug is bound to plasma protein. That means again very high protein binding. Any drug which is competing for the same site will able to displace propranolol, and thus adverse effect of propranolol can be there, or it can be seen. So these all things, just simple three lines are there. Absorb orally, you understood pharmacokinetics. First pass mechanism, metabolism, you understood. Bound to plasma protein, plasma T half 4 hours. That is a summary of all the pharmacokinetics, which you can, if somebody asks you for maybe 5 marks, you can extrapolate it because you understood it now, because you know the basic things which are there. Timolol is similar drug. It is used only for glaucoma. So timolol is not used for other systemic purposes, and other beta blockers are not preferred for the ophthalmic use. So timolol is more important in that case. Then everyone is facing same thing. Everyone is facing voice problem. So Ajit, you check. Ajit, you check. So next is alpranolol. It is a beta antagonist. It is non-selective, but it is a partial agonist. Now it's again very important. You know what is partial agonist? That means we have given the example of car. What we have seen that if the proper driver is there, can maintain proper speed, he can get number of more uh, visits or more turns. Okay, more number of times can go to and fro because they are true drivers. Partial is not able to do it completely, can drive, but not in the same speed as the normal can drive. So it is not exactly totally blocking, but it is slowing down. Okay, so these are the effect this partial agonist can have. Uses are same, uh, because as I told you, all beta blockers are used in various purposes. Adverse effects are almost same. See, thing is, depending on the specificity, it will be there. If it is non-selective, it is acting on bronchi and all other activities. But if it is specific, then we will not see the bronchial and other adverse effects. It is absorbed orally, metabolized by liver. Example or similar drugs which are having same activity, oxpranolol, pindolol, they are also similarly non-selective agents and having partial agonist activity. So when we'll study again beta blockers in cardiovascular system, we'll get the classification of beta blockers only. So in beta blockers, we have got such kind of activities. So propranolol was the first, and then all these classes, as we have seen, which are selective or non-selective, then selective with additional partial agonist activity, then non-selective again generation wise we have seen just now we have classified. There are some which are releasing nitric oxide. Okay, there are some which are having additional activities. So these all classification we shall be studying when we shall study in cardiovascular, but you can go through it now also. At when we shall go in cardiovascular, it will be easy to understand. Okay. Then next is metoprolol. It is a beta 1 antagonist. It is selective in nature. It is used in angina, hypertension, in dysarrhythmias. Okay. It is having less risk of bronchoconstriction. Why? Because it is not acting on beta 2 receptor. It is only acting on beta 1 receptor. And therefore, it is not having any adverse effect on other smooth muscle like bronchi or uterus or any other thing. Then it is absorbed orally. Then plasma TF is 3 hour. It is usually very popular in cardiovascular problems. and most of the time it is given as a parenteral one. The other drugs which is very popular is atenolol. Similar, it has got a longer half life, and it is comparatively more popular as a oral one, while metoprolol, although it is available, can be orally absorbed, but it is very popular in parenteral form. Then next is nebivolol. As I told you, nebivolol is having enhancing nitric oxide synthesis. You can understand, if it is doing more nitric oxide is causing vasodilation. So it is adding up the vasodilatory effect. Beta 1 is also causing antihypertensive effect. So they are typically used in hypertension. The adverse effects are fatigue and headache, because if the blood pressure reduces, less blood supplied to brain, and therefore these are the adverse effects. Then butoxamine is a beta 2 selective antagonist having weak alpha, but no clinical uses are known for that. Then important one, which are mixed alpha 1 and beta antagonists, very popular are two, that is labetalol and carvedilol. Having both, labetalol is having alpha and beta both. Uh, Carvedilol also having comparatively more beta and less alpha 1. Okay, so these are the actions these agents are having. Uh, they are used in hypertension, and particularly in pregnancy, labetalol is preferred. Then carvedilol is also a drug which is used in heart failure, can also be used in severe hypertension. The adverse effects are postural hypertension, bronchoconstriction, because it is non-selective, therefore can cause bronchoconstriction. Then the carvedilol is having similarly, and initially it can cause increase in the uh, signs symptoms of heart failure or renal failure, and then slowly it will come down, because because of the beta blockade, it will slow down the heart, and already heart failure is there, heart is not functioning well. Again, we shall study all the details when we shall study heart failure. So additional action may be contribute to clinical benefit. It is known to have antioxidant type of effects and all. Again, as I told you, we shall discuss this when we will discuss it in cardiovascular system. So these are all various antagonists which are used. These are the prototypes. I repeat, prototype means only one or other example is given. Their basic pharmacology is similar. Only other drug will have slightly modification in one or other activity. There slightly modification in pharmacokinetics maybe, and the duration of action, etc. So once we understand the basics, then what is easy to do is, you can compare it like that table you can make. If you make the table, this table will help you a lot. This table is for your own reference only, table is not required. This table is easy to understand, easy to keep it, but you should have read the details, and more details rather. So when you get this type of table, in this table you can add up the things uh, as a notes into that. So once you add this as a note, it will become easy, or if you wish, you can extrapolate this table. The drugs which are given in the last column, we can put in the same one after another. So group wise you can make, and then this table will help you a lot. So it is easy to understand because most of the actions are same. Only thing is, you have to remember, just like what you have to remember is, you have seen example is propranolol. Propranolol is causing bronchoconstriction. So propranolol is not suitable in bronchial asthma. Why? Because it can have action on beta 2 also, and if it blocks beta 2, then beta 2, which is bronchodilator, beta 2 is causing skeletal muscle relaxation. This blockade will cause less relaxation of the smooth muscles. So smooth muscle will be relaxed less, and because of that, what it will make is, it will contribute to the constriction of that. So this effect is not good in asthma. It is rather, it can cause increase in the asthma. We call it, the word is used is exacerbation. Exacerbation means already some problem is there, and that problem is increased by many fold. So that is called as a exacerbation. So it will cause exacerbation. Okay, so this exacerbation will be having a difficulty to the bronchial asthma patient. So we should be knowing. So we know the basic mechanism. Why it is causing? Because it is non-selective. So what will be better? It is better to give selective in that case. So like this, we understand, like this we apply, and from these basic ideas, that same information is carried into pharmacotherapeutics. In pharmacotherapeutics, when we have got so many drugs, and each drug has got some good properties, some bad properties, and considering this good and bad properties, how we should select the drug, what will be our criteria to select drug, that is given. Then there are many things are done for that, and on that basis, the now, as I told you, we have got more than 10 10 to 15 type of beta 1 blockers or beta blockers. Then which beta blocker should be used? Because we cannot say take any beta blocker. Okay, it's not a commodity, something like that. So we have to choose the proper beta blocker, and for choosing beta blocker, we should be aware about the pharmacology of this beta blocker in good manner. So you understood what are various antagonists? Okay, so these all antagonists we have studied. Uh, Now let me tell you that I have not received any type of difficulties or queries. I expected that this Monday we shall keep a class for the problem solving. But anyway, when you will put the problems, then we can conduct the class for problem solving. Problem solving, as I told you earlier, please go through the books, please read them, please read the text, because whatsoever I am telling, this is on the basis of what is provided in the text. Each and every line cannot be explained. You read it, but somebody can ask on that line. Okay, somebody can ask a short question. Somebody can ask, because examiner can be anybody, so can ask. It's better to read each and everything and ask the question. Okay, so keep it in mind. Anything can be asked, and it is a very vast one. It is better to read. You ask the difficulties, it will be easy. Okay, now next we shall go for the extension of cholinergic and anticholinergic drugs. Okay, these drugs now, adrenergic, we'll have an extension when we shall study cardiovascular and CNS. In that, adrenergic will be useful. So this basic, you have got time. No other classes are being there. I suggest you to go through this and read it thoroughly, so that it will be very clear to you.